This is part one of a two-part piece. Don't forget to check out the show notes for more details.
TopMedTalk.
Thank you for joining us for this first session of EdPom Ireland and EdPom Chicago. My name is Ramani. I'm a Professor of Perioperative Medicine at UCL and an anaesthetist there. Here to my right, I have Jim Down. Jim, do you want to just introduce yourself, please?
Jim Down, Consultant Intensivist and Anaesthetist at UCH, was working clinically through all the various surges in the last 18 months and was given the detail of ethics lead for the trust for a period and also generally helping out with rearranging the whole hospital. I continue to carry on my clinical role now.
Colin.
Good morning, everybody. Colman O'Loughlin. I work as a consultant in intensive care in the Mater Hospital, occasionally tolerated in the operating theatre as an anaesthetist also. I obviously was clinically involved in the local hospital response to the first, second and third waves, obviously, here in Ireland. I also was president of the Intensive Care Society of Ireland just after the first wave, took over from Catherine Motherway, and also part of the emergency advisory group to NEFIT, which is something I think is similar to SAGE, an advisory group to the government. So I've been involved in kind of various different levels, if you like, in something that was brand new to everybody.
So I did very little clinical work over the last 18 months. My role was working for NHS England, the overarching body that supports NHS hospitals in England, working as the National Clinical Director for Critical Care, which was mostly an office job, obviously quite a challenging one in terms of coordinating an emergency response around intensive care unit. I'm going to start with you, Jim. Tell us a little bit about UCLH and the sort of setup that you were working in over the course of COVID.
We are a London teaching hospital with a mixed general intensive care with a particular interest in infectious diseases and haematology oncology, and then as a hospital, big cancer interest. And we have a main ICU of 35 beds and then two satellite ICUs, one of 10 beds, one of between 15 and 20. And then we were due to open, in fact now have opened a fourth unit, which would be a surgical ICU and then a haematology oncology in the future. That's how we were running before it all happened. As it hit, we expanded in the first wave up to a peak of about 90 COVID patients, and we had elected in a separate site. So we carried on with our 10 elective surgical patients. And then in the second wave, we peaked at about 120 COVID patients, and again tried to keep the other work going on. We also used the local private sector for elective NHS work, so we moved a lot of our major elective stuff into the private sector, and in fact I did some work on the ITU there, which was a bit of a respite in a way. And like a lot of people, we expanded into theatres and we took over a floor of a normal ward in the hospital. So that was our sort of global response. We're lucky in that it's a new hospital. We had lots of oxygen. We were helped by lots of local hospitals, so particularly Great Ormond Street sent us consultant staff, and our colleagues from specialist hospitals locally, like the Moorfields Eye Hospital, sent us support staff, so we were very lucky in getting lots of people in. Also, a lot of our expansion was referrals in from other hospitals, so we took probably about 50% through the front door and about 50% from other hospitals. And I think one of the big legacies we'll probably come on to is that the collaboration regionally is now hugely different to what it was before. So that's one positive, I suppose, to come out of the whole miserable experience.
So, Colin, tell us a little bit about your personal experience at the coalface.
Yeah, I suppose one of the things, just geographically and the way this virus seemed to spread from the east towards the west, we were picking up learning points from other countries before we really got hammered by this virus. We realised very early on, we being the national government view on this, that we had a very, very constrained ICU capacity, where six beds per 100,000 I think is in the very low side in international averages. And we knew we would not be able to sustain the numbers that we're seeing in some countries as this virus is coming towards us. So we went to a very severe lockdown. I mean, we're talking tumbleweeds going down the main city streets. In the hospital, there was tumbleweed going down the main corridor. There was nobody at work. All elective activity was completely stopped, bar the absolute emergencies coming through ED, which again became unnaturally quiet. Constant stream of appendectomies all stopped for some reason, all these bizarre kind of phenomena started happening. But that severe lockdown prevented us getting those huge numbers we're seeing across Europe, and I think we got very lucky in that we never got overwhelmed in intensive care terms to degrees we were seeing elsewhere. That response really saved our bacon. Those huge knock-on effects which we may talk about on non-COVID patients But we managed to keep all patients within the ICU area in our hospital. Other hospitals didn't manage that, but we were lucky in our hospital to do that. We have a 36-bed critical care area with satellite step-down areas in the hospital, say for cardiac patients, for spinal patients, etc., for some high-risk medical patients. So we utilised all those, and again, I think that kind of surge journey has been explained and gone through lots of times. But I think it's important, I suppose, in another role that I played, I was sitting at the emergency advisory group to NEFIT, which is the advisory group to advise the government, that I was seeing people for the first time doing jobs that I kind of knew they were tasked to do. We have the HPSC, which is a Health Protection Surveillance Centre, which looks, I always thought they're the public health group. And my view on them for years had been they looked at all the measles outbreaks, all the mumps outbreaks. Didn't really think ever in my career would I have an interaction with that craft group, if you like. And so all these bits of the pandemic response, which we should have been prepared for, and I should have known what HPSC did, they should have known what I did, I should have known what the procurement side of our service did in terms of getting PPE. Nobody knew any of that. So preparedness was something that we really didn't have that in our radar at all. And that filtered down to hospital level, and I'm sure it was a similar situation. I know throughout Ireland there was screams of panic for PPE, for various different types of masks. There was a batch of aprons or gowns that were ordered, the sleeves went up to the elbows and stuff like that. All this kind of substandard stuff kept coming through. And so, so from hospital level and from kind of being involved in these national groups, it was fascinating, and it was very educational that we completely fell asleep at the wheel on this one in terms of preparedness. And so lots of learnings that we can go through those things in more detail. But the hospital response, again, I think is similar to every hospital. It was a surge into areas that weren't naturally set up for intensive care management, and absolutely depending wholeheartedly on the goodwill of non-ICU staff to come and bail us out, because not only did we have the numbers becoming very difficult, but a lot of our staff, like elsewhere, were becoming sick. We ventilated 2 of our own nursing staff in our ICU, which not only was that scary, but it was psychologically, it was extraordinarily damaging to the rest of the staff. So, I mean, it's huge challenges, and I look back at it now, and a lot of that seems to be distant memory, but it still lives with us, I think, it still does.
Yeah, it's very interesting. Thank you, Colin. I think about March 2020, and in my head, it's a really dark time, physically dark. It felt like the skies were dark and all the rest of it. And then when March 2021 came along, I realised that it's spring and everything's brightening up and all the rest of it. It's just that sort of psychological feeling of what it was like at the time. It's really coloured my memory of it. That preparedness issue at local and national level, it gives us food for thought for preparedness for the future, doesn't it? Because I think, as I understand it, at government level in the United Kingdom, in Ireland as well, the preparations for a pandemic were for a flu pandemic and not for a pandemic of this type, where you would need lots of additional ventilators and lots of additional critical care capacity. And that's the thing that took everyone by surprise, was that demand on critical care services. And in England, it was very similar, wasn't it, bringing in staff from other parts of the hospital. But I'm going to go back just to one of the first challenges we had, which was around equipment and PPE and, stuff that you can touch, the structures, and how that was dealt with and how we might go forward better in the future. So in England, there was a concerted effort to procure ventilators and build ventilators and PPE and all those sorts of things. But it was a challenge because the whole world was experiencing the same problem at the same time. Jim, do you feel that those problems have been solved now? Do you feel that in the UK, that from a clinical perspective, you feel confident that we're not going to have that challenge to deal with now in terms of the physical resources that we can deal with whatever this might have to throw at us this winter or in the future?
Yeah, so I think with the big second wave we had in January, it was quite interesting because we organisationally and sort of structurally and physically, we could deal with it. I mean, I think looking back to that beginning bit, it was just all uncertainty was the thing. How many, was it going to be 300? Was it going to be 1,000 patients? Was it going to be 5,000 patients in the XL Centre? Just the scale seemed sort of unfathomable. And then the disease obviously was horrifically different to what we'd expected and so much more complicated and unpredictable. So the idea that you could just, it was like a polio pandemic, was totally thrown out the window. So I think those two things together made the first surge very difficult to react to because we didn't know what we should be planning for in terms of scale or illness. And then obviously by the time the second surge we did know. And the thing that struck me was that the physical stuff, we were much better organised, and I'm sure everyone was. We used people in much better ways people who were doing things that they wanted to do rather than, you'll become an intensivist tomorrow. We were much cleverer, and we had enough good equipment. I, for some reason, felt that we'd have much better success rates, and of course, it's still a horrendous disease, and that really shocked me that still so many people were dying, despite us being better organised. In terms of your question, I think we are much better. I think we were culturally, the whole country was, if you look at the Far East, they're used to sort of these types of viruses, aren't they? They wear masks without thinking about it. We've always sort of just avoided them, haven't we? We've had the kind of cry wolf thing, so I think we've become a bit culturally, will never really happen to us. We'll have some flu outbreaks, but it won't. It's culturally, society and medicine to really take on what it meant to be in a pandemic. So I feel certainly now we've got a bigger capacity, we've got far more equipment, and as long as we don't have a surge bigger than we've had before, I think we could certainly do it. And as I said, I think the collaboration is a different world now. So even now in an endemic phase, there are daily conversations between all the hospitals in our area about who needs to move people where. We've got a transfer team. It's so much. The infrastructure between hospitals is so much better. You don't have that sort of bartering for a bed thing that you used to have now. It's much more open. Everyone knows how many beds everyone else has got. You can't get away with it anymore. No. And that feels infinitely better than just in terms of 8 million people who live in London. It doesn't matter really if you get ill in Edmonton or Chelsea. We'll find somewhere for you to go, which is a huge step forward, I think.
Yeah, absolutely. So, certainly, both England and Ireland, I've been hearing over the last few days, have got excellent vaccination rates in the adult population. But despite that, in England today, about a third of our intensive care beds have got COVID patients in them. So that a third of our capacity is filled with a disease that didn't exist 2 years ago. That's obviously having a very significant knock-on impact on staff who've had enough, quite frankly, of dealing with this disease, I think, but also on our capacity to deliver care. So online, we have Catherine Motherway. Catherine, what's the situation in Ireland at the moment? That's how it is in England. Are you having similar levels of COVID in the ICU despite good vaccination?
Not quite as high as you, I think. So I think today, I haven't looked at yesterday, we had about 64 patients in critical care, and we have a total critical care capacity of 300. So I suppose it's just over a quarter. We have quite good vaccination rates in the younger population, largely because number one, they wanted to get vaccinated, but number two, they couldn't go in to have dinner if they weren't. They couldn't go out, they couldn't socialise. So we do have what they might vaccine mandate in terms of eating out, which has really helped the uptake. And we're also vaccinating children. Now, the rates in children are not as high as they are in the older teenagers, but they are improving. We still have pockets, like everywhere, of unvaccinated populations, and I wonder how we will get to those people, because at least 2/3 of our patients in ICU are unvaccinated, and they're young. They're the pregnant population who haven't embraced vaccination as much as we would like, and they also are non-Irish people who might not be getting the mainline message, or who may not necessarily trust the healthcare system. So a large number of our patients are actually who are not vaccinated and young, are from different ethnic backgrounds. I think you would agree with me, Colman. That's what I'm seeing locally, and I think that's what most of us are seeing locally.
Colin?
Absolutely. Our hospitals are 150 kilometres apart, but I can say it's almost the exact same profile in our hospital. Just over a third of our patients are COVID, like you describe. In our ICU, they're ranging from 19 up to 40-something. We're not seeing that age group in the 50s and 60s at all. Half of our admissions over the last 3 weeks have been either recently delivered or currently pregnant. So that's a major challenge, because that brings a whole psychological side to the patient, their family. And as Catherine says, there's a cohort of patients who various different life experiences has led them to distrust state programs such as vaccination. And that could be either a childhood experience or a state experience in different environments, but it has led to a significant number of people being very exposed to this virus. And they're the people we're seeing at the moment. You can see that's a negative thing. In other ways, you can see that we have 90% of our population over the age of 12, nearly 90% over the age of 12 are vaccinated. I have my 15-year-old vaccinated almost 2 weeks ago. fully vaccinated. My 12-year-old will get the vaccine for her birthday in October. She's not too pleased about that, but she knows that. So there is huge uptake for reasons Catherine explained. But what we're seeing in the ICU is so clear to us that, it's, and I'm not sure if it's the right word to use, but it's been used around Ireland, a pandemic of the unvaccinated is what we're starting to see at the moment.
Thank you. So I think we're now joined online by Enda as well. Good morning, Enda.
Thanks very much. And just to briefly give you an update, I'm a consultant intensivist at St James's Hospital. We're a very big hospital, 1,000-bed hospital in the inner city of Dublin. We, at the beginning of the pandemic, we had, I suppose about 29 intensive care beds. We reached about 170% of our capacity with COVID, certainly not really anything along the lines of which I had to deal with over in the UK, really, but certainly stretched our system a little bit, just sort of breaking out into other intensive care areas and redeploying staff from elsewhere. I mean, we had to do all of those things. We didn't have in place beforehand, and we've certainly learned now and will be quicker and sort of more agile if we have further pandemics. Would be number one, I now know a lot more people in the hospital executive and across, say, bioengineering and that aspect. So, I'm on first name basis with these people, and that was sort of all the discussion we had about oxygen flows and devices and machines and equipment and all of that. So, those lines of communication are very, very helpful, and I didn't really have them before, I have to admit. The second thing was that work is best done in a team-based nature rather than maybe the more traditional approach we have to intensive care. By that I mean actually that COVID, though it was an enormous challenge, was an unusual situation because there was a homogeneity of disease and illness that certainly in my career I'd never seen before. That we were managing 17 people with effectively the same condition. We were actually able to apply teams. So for example, our anaesthetic colleagues were enlisted and helped greatly in terms of, an intubation team or a central line insertion team. We had groups of medical students actually who joined us, third year medical students, and they were our proning team, led by obviously senior nurses or trainees who'd be airway competent. And there were educational teams as well. And we recognised that although it was important to have as many nurses at the bedside, doctors and nurses at the bedside, ultimately it was a good use of resources to have some of those who were in charge of, say, 7 or 8 or 9 beds and would have an educational role to make sure that the redeployed staff would understand what ARDS was and what lung protective ventilation was as well. And I guess we have subsequently learned that what happened was very psychologically challenging for lots and lots of people, both those who would be ICU aware and ICU experienced, and particularly those who hadn't worked in intensive cares before. And I think there's been a lot of discussion about well-being, obviously, and how we'll have to sort of mitigate against that in the future. And we've certainly learned a bit there too. So they were kind of 3 important lessons, I think, that we've learned. We've kind of filed away, hoping that perhaps we won't have to use them again for any further surges, but maybe we will.
So I'm delighted that our colleague, Professor David Walker, is able to join us from London. So, David, the sort of task-orientated working that Enda's just described, and we've talked about already this morning, it worked really well, as I understand it, during the surges. You had an intubation team, a proning team, a lines team. You're an educationalist. How much of that do you think we should be maintaining going forward? Do you think that we should be carving out our professional roles a little bit more? But how do you feel that would change training and people's experience of working in intensive care?
Yeah, I think we've learned a lot. Initially, we were inviting people to become task-oriented rather, and I'm talking about physicians mainly here, inviting them in to be part of the team, to lead teams, to look after shifts and to engage in the full experience of intensive care, and reluctant to say, well, hey, what we really need here is a proning team. What we need here is an expert intubation team. And I think over the course of the first wave, and maybe Jim's got a comment on this, we were much happier to invite people to be task-orientated. And in fact, the teams who became task-orientated felt a lot better off for that. I think they felt they had a real role, a really important role. And then they could carve out the educational piece, the learning piece, the training, and the skill around that, rather than being called in as part of their day job to fix an intubation. They were strategizing across the whole unit. They had a view of the whole unit, and they began to enrich our daily practice. So yeah, it changed in evolution, I think, over the course of the first wave. And by the time we got to the second wave, we had no problem with inviting teams to raise their hand and say, we need a team for X, Y, and Z. And those teams who had become expert during that period were very happy and very confident. And I think that's what we grew between first, second, and now maybe third wave, is the confidence to handle, to deal with, and to strategize. So I think in terms of education, lots to learn, really. The big thing for me, we have been paying lip service, I think, constantly to this idea of MDT training. But if one thing COVID has brought home to me is the absolute fundamental requirement for MDT training, teaching, and skilling up as a group. And I think we became really tuned into that, certainly at UCLH in the second wave. And we're turning a lot of our education at UCLH now around to inviting people to join courses from a wide range of backgrounds, where once we said we were doing that, but actually there were courses for physicians or courses for nurses or courses for physios. Now we are really trying to bring people on board as a team. And that's what we learned, I think, in the first and second wave.
Thanks, David. So, Jim, you mentioned that one of your roles at UCLH was coordinating ethics discussions. Can you tell us a little bit more about what that involved and how it came about?
Yes, I mean, I think when in March, or end of February, March, there were these graphs that were terrifying, weren't there? There was a big discussion about, what would happen when all the traditional capacity was full. From that point on, whatever we did, it wouldn't be normal intensive care, either in terms of equipment or numbers. And there would be some difficult decisions at that point. And then as it hit, and it was clearly this disease that was not straightforward to look after, that became crystallised to me as much more important, because to look after the sick end of COVID, you needed as intense intensive care as you need for anything else. It didn't lend itself to a medical student squeezing a bag with some sort of pre-filled syringes that could just run at a constant rate for 5 days and then turn it off and wake them up. That wasn't... My big anxiety was, what should we do in that state? Should we focus on people with a good chance of recovery, or should we thin everything to try and treat as many people as possible in an environment where rationing is not something we overtly admit to, although clearly healthcare is resource limited, so we're always rationing in some way, in that otherwise you'd give everyone everything. Clearly, there's a sort of discussion much more broadly about what we do day to day and how that changes in a pandemic. But the other thing was, we just didn't know how far that was going to go and what type of decisions we would be making. And very reasonably, people weren't able or prepared to say from higher up, which you know more about than me, you can go into these modes, because it's enormously difficult, particularly when you're dealing with something that's brand new. So we did a couple of things. We examined the ethics and went through them as a group, and we set up a trust-wide ethics group with lots of lay people on it, judges, religious leaders, our chairman of the trust, who's a legal background, and a rabbi. I think the main thing that did was to give us some feeling of support, feeling that we weren't making these decisions in isolation. And then the other thing we did, which I'm sure a lot of people did, was we, right from the outset, set up a 3-people group, so that you never made a withdrawal decision on your own. Because we changed our rotas, there were always 2 other people you could talk to. And that meant that every discussion, we had a pro forma on our system where you talked about what the decision you were making, what the issues were, what the outcome was. It was very structured, formalised, and you had to have unanimity to make it. And looking back, I'm incredibly glad we did that. Because,
is it something we should always do?
Well, yes, we're much more open to do it now, I think. In fact, we still have them. I was on this weekend and we had one on Sunday.
The 3-person discussion.
The 3-person discussion. And we've completely changed our rotas now. We used to be on our own at the weekend. Now there are 3 of us. 1, it's much less stressful. And 2, it feels like much better medicine, because your biases and emotions and all the other things related to that patient are diluted by fresh people coming in. So I think it's another great step forward. What we didn't see was what was going on before intensive care.
That sounds like a great system that's evolved. But surely we should be having those sorts of systems in primary care.
Yeah, so in many ways, I think intensive care was it's not the easy bit, but it was we were protected. We had PPE. All the staff came to us, particularly in the London Teaching Hospital. 5 consultants just came and joined us from another hospital. So In a way, I think the story of the pandemic, it'll be about primary care, care homes, and then all the different levels of escalation and what did and didn't happen. I think those decisions need to be made in a robust way from the beginning.
Enda, did you have a similar experience in your place around sort of setting up these, or did you have them before, the sort of more formal sort of decision-making around ethical decisions?
No, we didn't actually have them before. Actually, and a point that Jim was making there, just as a slight aside, I was at dinner there the other evening, and my family was saying that there was a programme on TV, I think it was called Help, a sort of a drama about the outbreak of COVID in a nursing home. It wasn't a drama about intensive care and COVID, it was a drama about the primary care setting, the community setting, and it sounded like it was quite well delivered. From the point of view of ethics, no, we did not have anything in place that was satisfactory beforehand. There was lots of national discussion, as Catherine and Colman no doubt will attest to. There was lots of national discussion about how best to tackle this, because one thing COVID did, it enabled us to view the amount of beds that we had in intensive care in Ireland as a whole to some degree, because we have a very well developed transport medicine system, and certainly I think it's better developed now coming out the back of COVID. But what we did locally, we did have 3 people who made those decisions. 2 of those were generally intensive care, and one of them were always what we would call the primary physician, who would be we had a set of respiratory and general physicians who were involved. What we did do was actually quite useful was once a week on a Friday, we had a sit-down discussion with the acute physicians, and we discussed all the both difficult cases that were unwell on the ward who may need to come to intensive care, but also we discussed the marginal cases, and I don't mean that in a derogatory way, but I mean those patients who are near the margins of needing intensive care and whether they would or wouldn't be appropriate for an intensive care stay. What we attempted to try to do was to set the bar of ICU admission at a level that was fairly fixed. And again, we were probably able to do that because we weren't swamped in the same way as some of the British intensive carers are. And by that I mean, we tried to make it a bar that didn't change height depending on whether we had beds or not. Fortunately, I think for really all of the pandemic, we were able to achieve that. And that bar was set. We probably now use things like the clinical frailty score and the frailty index a little bit more than we did. We know a bit more about that, and we try to apply as much evidence as we could to an objective assessment and a bar level below which we would accept patients to intensive care and above which we thought that they would not be appropriate for intensive care. So probably what we do better now, I think, is we have greater discussions with the pre-ICU teams. We definitely have a team-based approach now to making sealings of care and end-of-life care decisions. And we probably have a greater recourse to using more evidence-based tools such as frailty index, functional status, that sort of thing, to help us decide which patients are appropriate and not for the intensive care.
Jim raised an interesting point about where we thought we were going to be at the beginning of March last year. So our intensive care capacity in England is about it was about 3,800 beds at the beginning of March last year. It's a bit more now for obvious reasons. We thought at one stage that we may be, 30,000 looked like, something that might be on the optimistic side. And as Jim has said, we were building Nightingale hospitals, at pace and all those sorts of things. So one interesting ethical discussion that was had, and the Chief Medical Officer set up a national version of the sort of thing that was established at UCH to opine on the ethics of if we got to the stage where we thought that rationing might be a realistic option, large-scale rationing, what would we do? And then that was disbanded because, thankfully, partly because we were never overcome in the same way that had been feared. There is a problem, though, isn't there, in that, so the most basic measure is the nurse-patient ratio, which is a really basic measure. It's not a good measure, I don't think. And we've all talked about how we can do better in terms of task-orientated working and all the rest of it. But we stretched our nurse-patient ratios from 1:1 to 1:6 in some places because of the number of patients coming in. So that sort of thinning out of the service delivered, the care delivered, as Jim has described it. So the ethical question is, thankfully we weren't we got to the start. I don't think there were many, if any, places that had to go further than 1:6, and I think the other 5 beds all had nurses next to them, but they weren't intensive care nurses. But Colin, do you think ethically the right thing is just to keep stretching and stretching and stretching and stretching? Because that's what I think, just to put my cards on the table, I don't want to have to make a decision or ask someone else to make a decision on arbitrary means.
I must say, I find it fascinating, and I'm Looking at this brings back some very strong memories of those meetings we used to have to discuss triage of patients. We were lucky, I suppose, that we had, I think Enda referenced, a national document produced by our chief bioethicist who wrote a document, Ethics in the Time of a Pandemic, and there was a fairly clear section on intensive care medicine and the concept of triage. So we borrowed heavily from that. It was along the lines of what we were thinking anyway. We borrowed heavily from that, and again, we did bring in the 3 team of individuals for those difficult choices. We were lucky with our complete lockdown. Their numbers never got to the point where we had to triage and ration services. We just got very lucky on that one. We had thought about what might happen, and we had this, I suppose, plan of how we get the message across to the public, because I think some of the messages of how intensive care is delivered, even in pre-pandemic times, wasn't clear to the public. And why should it be? Intensive care has people out there, Joe, so thinks about it on a regular basis, and I'm glad they don't. But one of the things we wanted to get across was that in normal times, it is a normal part of hospital medicine, ICUs, not to admit every patient to intensive care, and that there are patients where the burden of the interventions far outweighs the benefits. I think that was a very important message to come across early on, showing that we already do a kind of a triage of where, as I said, the benefit is not there for everybody in intensive care. It's a very demanding clinical area to be a patient in, and can be very I suppose, it can be very undignified if we put patients who don't have any capacity to improve through a very burdensome intervention. So that message we want to get across very carefully. And the other message is where your point lies with, we have standards, and our standards come from our joint faculty, and we borrowed heavily from international standards. We have standards of care that we like to deliver to our patients. And I think, we look at ICNARC numbers, we look at our numbers throughout the last 20 years, and we have a very, very good standard of care in intensive care medicine. Our outcomes are fantastic, but it's because we have those standards. So our second message was, one was, as I said, not to have that message, not everyone benefits from intensive care. The second was that the more of these patients come in, the harder it will be for us to stick to our standards. Our standards of one-to-one nursing there may be other ways of looking at that, but that was an easy one to kind of get the message across. We have it in a one-to-one nursing, and in our centre we've ECMO. We've 2 nurses to 1 patient in ECMO, which really made it very difficult for us to stretch. But we had to stretch. We certainly had to go to areas where it's 2 to 1. But we constantly got that message across to people through myself doing media appearances, Catherine did a lot of media appearances as well, where we kept identifying our standards will not be able to be upheld if the numbers keep coming in.
So there was a lot of transparency, was there?
We tried to be, and again, it wasn't, and I think Catherine will speak to, because I certainly was not comfortable in the media, still not very comfortable in the media, but we felt it our obligation to try and get those messages across. Catherine was fantastic at it, actually. We tried to say we have standards, we'll uphold them, but if the numbers keep coming in, the standards will change, and by virtue of that, we can't guarantee those good outcomes you can see on our ICNARC reports in the UK. Those standards will drop, and patients will suffer because of that. We tried not to bring in the concept that we would ration if it came to a certain point. We kept saying, rather than this patient, 2 patients, we kept saying standards drop, mortality will increase. In a more generic way than pointing out individual triage decisions. But as Jim mentioned, it even happened as recently as in his hospital last weekend. We never got to those points, thankfully, but we did get the message across, if you like.
Catherine, do you want to come in on that, on the sort of the media work that you guys did around informing the public? Because also you could take that as an opportunity to inform the public of their role in helping to suppress the pandemic.
That, I think, was a very big role. And we had a very frank discussion with the public. Our message was, 1, the non-pharmaceutical methods in not getting the disease kept everybody safe, including people who didn't have COVID. That was the initial message. And then we did have discussions on various media outlets about the fact that if we got overwhelmed, outcomes would be poor. And we were asked to triage. We said we hadn't got there, but we did make a public commitment that if we got there, we would have a public discussion about it, because I think it's very important that it depends on resources. If you are in sub-Saharan Africa and you get COVID and you need to be ventilated, and there's 1 ventilator and there's 10 of you, then only 1 of you will get ventilated. And, standards do differ across the world. And we are very lucky to live in a country where we have oxygen, steroids and ventilators and staff to run them. And we made public reference to that in many interviews. And the public got it, I think. And I think that's part of one of the reasons why our lockdowns worked to a degree. I think that all medical personnel across the specialties, both from GPs and to intensive care to others, were very honest about what was about to happen, or what we thought was about to happen. We were involved with the Department of Health in terms of the ethical document. We were involved with the Irish Medical Council in terms of the ethical document. And we did have many debates ourselves at society level about ethics and how we would cope should we get overwhelmed. And thankfully we weren't. And we did move patients a lot between hospitals throughout the country during that period of time to ensure that patients got properly served. But I do think that part of the ethics and part of triage intensive care is not necessarily a medical decision, it's a societal decision in one sense. Society will decide what's acceptable. And if you are going to have to triage at that level, then you have to have that as a public discourse and tell people. If you're going to use age, tell people. If you're going to use clinical frailty, tell people. We're very honest, as someone says, about the fact that intensive care is not a road that is right for a lot of patients. And we do that all the time. And we said we'd apply the same type of standards as we did throughout this pandemic, as we normally do. We'll go and see the patient. We'll see if they can benefit. If they want intensive care and we can give it to them and they will benefit, that's what will happen. So we discussed all of those things very publicly on a number of media forums, including a public educational session, a meeting that the Intensive Care Society has had twice now after a charity cycle, where there had been a public part to our scientific meeting where public could dial in and watch some speakers.
Thank you, Catherine. Jim, you wanted to come back on that?
No, just very quickly about this, we didn't officially ration, but I mean, I watched the drama Help, and I'm not going to, completely base my argument on a drama, but clearly, if you were in a care home, there was rationing. You wouldn't get an ambulance as quickly to you as you would to a 30-year-old. The care homes were not top of the priority if you were. So I think we may not have overtly rationed in ICU, but I think back in the primary setting, the pressures caused a lot of people not to get as quick attention as they would in a non-pandemic time, as far as I understand it.
So there may have been rationing. I haven't watched the drama, so I don't know. But the ambulances being diverted to younger patients or, not care homes, for example, that's more about the sort of allocation of resources and the balance and so on, and which is, I think, slightly different to rationing, perhaps.
This is part one of a two-part piece. Don't forget to check out the show notes for more details.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.